This podcast is brought to you by Podcast Nation.
With summer just around the corner, many of us are looking forward to upcoming vacations and beach days with friends. This summer, I'm going with my family to Gulf Shores, Alabama. You may not know, I grew up in Georgia and we went to Gulf Shores on the Alabama coast every single year. And it is one of my favorite places to be. And although I'm excited for this trip, it always takes a toll on my skin, using extra sunscreen for protection and not always washing my face at night. So I don't really want to deal with a complicated skincare routine while I'm on my vacation. And that's where customized apostrophe acne care treatment comes in. My skincare routine is just 3 steps, and the customized treatment keeps my skin glowing without any of the fuss. Personally, I love access to an expert derm team and no need for an in-person appointment or trip to the pharmacy. We have a special deal for our audience. Get your first visit for only $5 at apostrophe.com/AAW when you use our code AAW. That's a saving of $15. This code is only available to listeners. To get started, just go to apostrophe.com/AAW, click Get Started. Then use the code AAW at sign up, and you'll get your first visit for only $5. Thank you, Apostrophe, for sponsoring the episode. Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello, and welcome back to the As a Woman podcast. I'm Natalie Crawford, and I am your host. And today I am thrilled to do one of my favorite episodes, and this is answering your top fertility questions. These episodes are my absolute favorite because it's just a way to really connect with you and understand what you're asking. And because I get asked so many questions on a daily basis, those of you who take the time to send in a voicemail, I love that we can just get to it and answering them. So before we jump in, a few housekeeping items. Number 1, if you want to call and leave your own voicemail, 657-229-3672 is the number. Again, 657-229-3672. Call and leave it. It can be 100% anonymous. We will hear it, but if you don't say your name, we don't know your name. Number 2, we're not going to be doing For Fertility's Sake our weekly Q&A this week because we're answering these questions, but we will be doing it next week. As a reminder, I answer your questions on the podcast, on Instagram, and in the newsletter. You can ask these questions on Instagram on Mondays at Natalie Crawford MD. You can also ask fertility questions. Here's a little side note. On Fora Fertility's Instagram on Thursdays. That is at Fora Fertility, and Fora is Fora. And in the newsletter, I go over recent updates, fertility in the news, which is my hot take on all those hot fertility topics, and I'll answer your fertility questions as well. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter, and we'll get to it there. So without any further ado, we are going to go ahead and jump in to your questions.
Hi, Dr. Crawford. I have a question regarding PCOS. So I have PCOS. I am completely anovulatory without ovulation induction. So I have an AMH of about 11, and on my ultrasounds, my ovaries have between 25 to 40 follicles per ovary. So we've been working with a fertility specialist, and my husband's semen analysis is normal. I've had an HSG. The only diagnosis I have is PCOS. We've done 5 rounds of ovulation induction with letrozole, and this is our first with IUI. We have yet to see a positive pregnancy test. If this doesn't produce a pregnancy, we're going to move to IVF. But my question is, should I expect the same level of difficulty conceiving with our second? God willing, we get to have a first. So with women with PCOS, you typically see about the same level of difficulty getting pregnant, an easier time, a harder time. Just thinking forward to hopefully our second. We'd love to have a bigger family. Anyway, thanks so much. I appreciate all your knowledge and resources. It has been a lifesaver over the past year since my diagnosis. Thanks so much.
All right. Well, this is a really good question and something I don't think we talk about very often. So to answer it in a couple different parts. Number 1, PCOS does not get cured or improved by pregnancy. Pregnancy doesn't change the nature of the disease. People with PCOS can occasionally ovulate. I know we said we're totally anovulatory here, but I think answering the question about can you get pregnant afterwards, people with PCOS can get pregnant. It just becomes so unlikely. So I usually tell anybody who has PCOS and needed treatment that when they're ready for their second, do not waste time, just come right on in. And we usually pick up with the treatment that worked. So in the world where potentially this treatment cycle worked, that is what I would start with, ovulation induction plus IUI, when you are trying for your second. So we expedite to the level of care that was successful. So hypothetically, yeah, you are going to have the same level of difficulty getting pregnant, potentially more, because now we have age-related issues. It's further in time, and our natural pregnancy rate declines as we get older. And there might be variables that we don't know, scar tissue from a birth, worse sperm counts, things like that. However, this is why IVF is hugely advantageous for people with PCOS. I know it's not often our first line, but if you either do not respond to ovulation induction medications or do not get pregnant and need to move on to IVF, some of the advantages are, number one, you might get more than one normal embryo for your age. I do think this is a huge reason why I like to do genetic testing of embryos, so I really know what I have. But having genetically normal embryos, each normal embryo has a 65% chance of turning into a live-born baby. So if you go through the process, people with PCOS tend to have more eggs. If you therefore have more normal embryos, you probably will have enough embryos to save for a future pregnancy. So I like to have at least 2 normal embryos for every future baby. 3 would be awesome because things don't always go perfectly. But let's say 2 to 3 euploid or normal embryos for every future child you want. Now, if you do IVF, now you get pregnant and you come back and I have this stack of embryos, no, it's not going to be hard for you to get pregnant. So one of these advantages is it does free people from this infertility cycle by doing IVF and having normal embryos, because then you can just get to that embryo transfer. And most embryo transfers work. Most people are pregnant within 2 transfer cycles. And so if you have extra embryos, you won't have to go back through this. This is also why people who don't have PCOS will often do multiple cycles, even if they get a normal embryo in the first one, or why I'm seeing younger people do genetic testing so that we can really have an assessment. Because if I have 5 embryos in the freezer, that sounds cool. If only one of them is genetically normal, I'm going to feel very different about it. And this is called embryo banking, where maybe we are stacking up cycles of egg retrievals because we are the youngest we're ever going to be, we have the most eggs we're ever going to have, and they're going to be the most genetically stable because we know these things get worse with time. And we are trying to set ourselves up for not just our short-term goal of right now, but also our long-term goal of having that bigger family. I know it's one of Oprah's favorite things, but it is also one of mine. You know what I'm talking about? It is Cozy Earth. I have got to be honest. I love Cozy Earth, from the loungewear, the pajamas. It is my favorite gift to give my friends, anybody in my life, and every bed in my house now has Cozy Earth sheets. Because the products are premium, it's a wonderful gift, and it's just so amazingly soft and breathable. The bedding specifically is even temperature regulated, and the fabrics are the perfect option as the weather now is starting to get warmer and summer is officially here, especially in Texas. If you're looking for a Father's Day gift, go ahead and go to CozyEarth.com to find the best thing yet. Cozy Earth has provided an exclusive offer for all of my listeners today. You can find 35% off site-wide when you use the code AAW. Again, go to CozyEarth.com and use the code AAW for 35% off. This show is sponsored by BetterHelp. It's so easy to get caught up in what everyone else needs from you, everything on the to-do list, and all the craziness of this time of the year, that I know it's hard to take care of yourself and think about what you really need. This can cause you to be stretched out and burned out. But therapy can give you the tools that you need to find more balance, whether it's learning positive coping skills, how to set boundaries, how to be the best version of yourself, or processing and handling your emotions. I know for me, therapy has been absolutely life-changing. And so if you have ever thought of starting therapy, give BetterHelp a try. It's entirely online, designed to be convenient, flexible, and suited to your schedule. Find more balance with BetterHelp. Visit betterhelp.com/AAW today to get 10% off your first month. That's BetterHelp, HELP.com/AAW.
Hey, Dr. Crawford. Thanks so much for this opportunity to ask questions via voicemail. I have a question. I was recently diagnosed with PCOS, and I have been using the Mirror tracker for about 2 years now and wanted to know your thought on the best forms of tracking ovulation for those of us with PCOS. Let me know. Thanks so much.
This is another really good question, and I do find that tracking cycles is much harder with PCOS. It's not impossible, but it does depend on your exact circumstance. So let's just say there is no one size fits all when it comes to this. Number one, if your periods are so sparingly irregular at intervals of 45 days plus or more, it's going to be so hard to track. And I would at that point go see a doctor and get started on ovulation induction medications and let them track, whether it's with ultrasound, post-ovulatory progesterone levels. If your cycles are just irregular, but they do come, and you do believe you are ovulating with your PCOS, just not ovulating regularly, then I really like an ovulation predictor kit that is simple. Too many hormones can often overwhelm people with PCOS because your basal estrogen level tends to be higher from all the follicles. So some of these trackers that track high fertility with estrogen levels, those are just going to be so thrown off. What we want is something that's going to detect just that LH surge. So I typically like a very simple test that is only checking the LH surge. You need to use this test at the same point every day, and you should start immediately after your period ends, at least the first cycle. If it tells you that you're already surging, okay, so let's say you take it cycle day 7 when your period is done and you're already getting a positive, then you know you cannot use this. And this does happen because some people, not everybody, some people with PCOS, especially the higher your AMH is or the worse your disease is, they tend to have such high baseline LH levels because they're making so much testosterone that you'll always get a positive. And then you know OPKs are not reliable. But if you don't get a positive, then you can check it the same time every day, which is between 10 a.m. to 2 p.m. So that middle of the day range, and you can wait. And when you see that first surge of a positive, that will be the LH surge, and you would target intercourse for that day and the next day, and then do not check it anymore, because LH is going to be rising and falling throughout that entire luteal phase. So don't keep repeating it over and over again. I will caution that a lot of people with PCOS do have a hard time tracking cycles. So sometimes I say, if you do know you're ovulating because you do get actual periods, you can just have timed intercourse starting cycle day 10 or so every other day for a period of time, and you're going to cover it. But the reality is a lot of people with PCOS do need ovulation induction help. When you're doing ovulation induction help, I never tend to rely solely on an OPK for my PCOS patients. And so I would ask, can you get an ultrasound? Is there another way to measure it? Can you get a progesterone level after the expected ovulation if you do use an OPK? So let's say your doctor's office does like these OPKs, then what I would say is, I have had these be unreliable. I am hoping this medication helps it, but can I come in a week after my positive and get a progesterone level drop? And what you're looking for, that progesterone draw, is for it to be 3 nanograms or higher. And if it is, you did in fact ovulate when you saw that positive, and then you can use that in the future, knowing that it is reliable if you don't get pregnant.
Hey, Natalie. I had a quick question surrounding ovulation and tracking, trying to conceive. My husband and I have been trying for the past 4 months. We were very blessed during our first pregnancy, getting pregnant relatively fast. But actually looking back on it, the time that we were trying to conceive was actually not the time that my son was conceived. He was actually conceived about 2 weeks after what I anticipated my ovulation time to be. I had tubercle mucus around that time. It kind of aligned with the dates that I had my period, but it actually turned out to be around the 25th day of my cycle. After having some tests and things of that nature, turns out that I do ovulate, but my ovulation is kind of inconsistent. I do not have PCOS. After having some tests drawn, everything seems to check back normal. But I was just curious if there was anything that I could do to kind of track that, to kind of have an understanding of what to look out for when it comes to ovulating. My husband and I do both have pretty low libidos, so we're trying to figure things out that's going to work best for our family, but also not be too much of a stressor on our relationship, trying to kind of work through that. So I was just curious if there was anything that we could do or I could track to kind of offset that possibility of having longer ovulation cycles and it not matching up with cervical mucus and other symptoms to check for ovulation. Thanks. Bye-bye.
All right. So one of the hard things is that cervical mucus can be very effective. It's definitely free, so that's awesome. But it is influenced by so many things. So one, what is cervical mucus? Cervical mucus is the mucus that is around the cervix that is preventing sperm from entering the uterus, except the time when you're ovulating. So it goes from more of a barrier to a pathway where the sperm can get through. Stage 4 cervical mucus is what we call egg white and sticky. This is not what you just see maybe in your underwear. You actually need to put your fingers inside and see if you can grab and pull anything out. And if you can and you stretch it, it looks like an egg white. That's actually your type 4 cervical mucus, and that is typically consistent with the day that you're ovulating due to the high estrogen levels changing the consistency of the mucus to allow sperm to get through. Now, medications, having allergies, drinking alcohol, not getting enough sleep, a lot of things can influence your cervical mucus. So it certainly seems like in your situation, that's not a reliable external sign. And maybe we know why, maybe we don't. It doesn't really matter. If you don't use PCOS, I'm curious if you've tried using the ovulation predictor kits like I previously said, or a wearable. So let's go over both of those. Ovulation predictor kits, again, are checking the LH surge that comes from the brain. These can be hard in PCOS patients because of endogenously high LH, but in somebody who doesn't have PCOS, your LH should be low until you get to the stage where you're going to ovulate, in which you're going to have a surge. So if you start taking these tests around cycle day 10 for the average person, take them one time a day between 10 a.m. to 2 p.m. The day that you see a surge is going to be the LH surge day, and your ovulation is the next day. So if you have low libido and you're trying not to overwhelm your relationship with too much intercourse, targeting those 2 days, the day of the positive and the next day, are going to be the most reliable. Now, it's important to try to understand why your periods are irregular, and hopefully you've had the full workup since they ruled out PCOS. But remember that things like thyroid disease and prolactin and running out of eggs can all influence your hormones. So I would want to make sure that you've had a TSH, a prolactin, and an AMH done so that we know what is going on. There's definitely reasons why people have anovulation that we don't always know about, meaning having mild hypothalamic disease from a prior eating disorder, from being stressed, from being in a calorie deficiency, can decrease the FSH secretion from the brain and not be strong enough to get us to ovulate. Being overweight, so those fat cells can make estrogen, and that means that the brain is not sending out a strong enough FSH signal, so it can take us longer to get to ovulation. And so those things can lead to chronic anovulation, and they are different entities than PCOS. However, in those circumstances, you should see an LH surge. So I would consider trying to track that. The other thing is a wearable that is checking your temperature. This can be now a variety of different wearable options, and this has made basal body temperature tracking much more accessible. This can be tough if your periods are very irregular and it's predictive in the prior. So if you don't ovulate perfectly, but you do ovulate, and let's say your cycles come every 36 to 40 days, this is going to tell you approximately when you ovulate based on your temp rise, which happens a few days after ovulation. So it doesn't help you in the moment, but it does help you if your cycles are consistently the same length in understanding when that fertile window is, so you can just target that for intercourse versus tracking it anew every cycle. But if they're slightly irregular, you don't have PCOS, we've ruled out thyroid disease, prolactin, running out of eggs, we would try an LH test if we think that we're ovulating. Just any from over the counter is fine. You don't have to do anything fancy.
So you open Google Chrome on your phone, you're hunting for a super rare first edition vinyl of a band you're obsessed with, when you're supposed to be working. But this site you tapped on seems pretty shady. And Daryl from IT just jumped up from his desk. Oh no, He's coming your way. It's a good thing built-in malware protection keeps you safe and sound. Not from Daryl, though. Sorry. There's no place like Chrome. Download Google Chrome on your phone.
Anyone who knows me in my real life has seen me walking around for the past week with my Nutrisense CGM. What is a CGM? It's a continuous glucose monitor. It's a small device that tracks your glucose levels in real time. The application is easy and painless, I promise, and each device lasts for 14 days. You can use the app to scan your CGM, visualize the data, log your meals, run experiments, and see how your body responds to food, exercise, and sleep. There's also an expert dietitian who can guide you, and each subscription plan includes 1 month of free dietitian support. Visit Nutrisense.io, that's Nutrisense.io, and use the code AAW to save $30 and get 1 month of free dietitian support. Be sure to let them know you're a listener of the As a Woman podcast when they ask how you heard about them. Again, that's Nutrisense.io and use the code AAW to save $30. As the weather is warming up, I don't know about you, but I am back to shaving my legs. This is something that admittedly I do not do all the time in the winter. But now that it's summer, it's Texas, I'm in bathing suits and shorts all the time. I am loving the Athena Club razor, and I don't know if you have tried this yet, but I want you to know a little bit more about it. Athena Club's razor has thousands of 5-star reviews because it has built-in shin guards to prevent razor burn while being gentle on all the curves of your body. The razor blade is surrounded by a water-activated serum with shea butter and hyaluronic acid, which is the holy grail for skincare. And the best part is the razor kit is only $10, comes with 2 blade heads, a magnetic hook for shower storage, and your choice of razor color. Mine is blue. You can show your skin you care with the Athena Club Razor Kit. Head to athenaclub.com and use the code AAW for 25% off your first order. Again, that's athenaclub.com and use the code AAW for 25% off. Athena Club has also launched in Target stores nationwide, so make sure to check out the shaving aisle to buy their products in the store in real life.
Hello, my name is Rachel. I got off birth control about a little over 3 months ago, and after being on it for 12 years, and I still haven't gotten my period, and just trying to figure everything out. My FSH and LH are both 6.3. All of my thyroid hormones are seemingly normal. The only one that's a little low is the free T4, so 1.18. So yeah, just kind of trying to figure out what is going on, what could potentially be at play, and how to get back on track to get pregnant ASAP.
All right, so when you have amenorrhea after using a hormonal contraceptive, so in this case, it is the birth control pill, but we also see it after a progesterone IUD or an arm implant or the Depo-Provera shot. It can be for a variety of different reasons. Most of us think that it's because of the brain, and sometimes it is, but it also can be because of the uterus. So the first distinguishing factor is, did you have periods while on the contraceptive? Meaning, a lot of people with an IUD or with the pill use the pill continuously, or they've been on it so long that now that chronic progesterone exposure has made it so they no longer have periods. And that can be great. You don't have periods, you don't have pain, you don't have cramping, you don't have bleeding, you don't get anemia, but chronic progesterone to the lining of the uterus over a prolonged period of time can make it so thin, that's why you don't bleed, that it can take a long time for it to come back. The other thing that can be going on is that you may not ovulate, and trying to get to the bottom of the reason why is what we're doing now. So if you took the pill, I'll put in quotes, like normal, and you had a bleed every month, and now you've stopped it and you've had no bleed for 3 months, this does typically present an underlying ovulatory issue. So we have some of the values, but not all of them. You said FSH and LH are in the 6s, but what is your estradiol? Those are important to understand together. If your FSH is 6, but your estradiol is very low, then you're not stimulating an egg to grow, and this could be part of the hypothalamic phenomenon, meaning I would want to look hard at our history. Are we over-exercising, training for a marathon? Are we under-eating? Are we in a malnutrition state? Do we have a history of an eating disorder? Are we on weight loss medication trying to lose weight weight and losing it rapidly? Do we have a chronic disease? Are we under a high level of stress? Are we not sleeping? A variety of these different things can cause hypothalamic amenorrhea, and this is something we definitely see when coming off the pill because now the brain is not turned on. Another thing that we see can be PCOS, and FSH and LH are not part of the diagnostic criteria for PCOS, so we often would want to look at the ovaries to see if they have a PCOS-looking appearance, meaning there's a lot of small follicles in them. Other clues I can point to it can be a high testosterone level, although coming off the birth control pill, you actually usually don't have a high T, so I wouldn't check it this close to the pill because the pill changes something called sex hormone binding globulin and manipulates your testosterone, which is why people who have acne can really love the birth control pill because it lowers testosterone levels. But what we're looking for is, do you have a high number of follicles? And maybe the brain is sending out that normal FSH and it's just getting diluted amongst all of those follicles. In this circumstance, your estrogen is going to be normal or above average. So what I mean by that is in hypothalamic, your estrogen's typically 20 or less. In PCOS, that estrogen's typically in the 30s to 60s, depending on the scenario. And then we also have scar tissue inside the uterus, which can play a role. And this is unlikely after the pill, although we do see it sometimes after an IUD. But I will use the exception that I've had some people who had a traumatic loss, a termination, a miscarriage, and then started the pill right away. And so they never really knew if they had issues inside the uterus. This, again, would be a scenario where you would be not bleeding on the pill. So if you had periods on the pill or not is changing how I'm looking at your body. By the 3-month mark, the suppression from the brain that the birth control pill does have should be removed. Meaning when you're taking the pill, you're giving the body estrogen, and so the brain should not be sending out FSH. And typically FSH and LH levels in this scenario are very low, 0, 1, and 2. So the fact that they're both 6 does say that that brain suppression from the pill has been removed. However, is it a strong enough signal to make the ovaries respond? What is happening? If all of the levels are pretty normal, your doctor might do an ultrasound to see what the lining is, or might do what we call a progesterone challenge, which is giving you progesterone to see if you will bleed afterwards. It's a soft sign to see if there was estrogen to grow the lining. We're really looking at having no estrogen versus having estrogen. Having estrogen can be PCOS, being overweight, puts things in that category. Having no estrogen typically means you're either hypothalamic, menopausal ovarian failure, which you're not because your FSH is 6. But that will put us in one of these 2 categories. So we're not ovulating if that's the case, and we want to figure out why. And it can be frustrating, but please consider really staying on top of your doctor or seeing a fertility doctor. And if you're wanting to get pregnant, you're going to need some help with ovulating. So I would just fast track it into the fertility clinic.
Hi, Dr. Crawford. Thank you so much for your podcast. It's been super helpful and informative during this process. I am a 34-year-old, well, 33, my birthday's tomorrow, so almost 34-year-old woman who has regular periods but was recently diagnosed with diminished ovarian reserve. I have high FSH levels. I've done 2 egg retrievals, and I've gotten 10 embryos that we PGT tested. So we actually had more than that. The 10 are the quality embryos that we have frozen. I have done 2 frozen embryo transfers of the day 5 blastocyst, and both of those transfers failed. I'm currently starting my protocol for my 3rd transfer, and I'm just kind of jaded and nervous about this cycle. The first failed cycle, we did progesterone and estrogen. The second one, we did a Lupron lead-in, then progesterone. For this cycle, we are doing just the standard estrogen for 14 days and then 6 days of progesterone. They also have me on supplements. I will be taking Viagra 4 times a day vaginally, as well as L-arginine, I can never say that right, vitamin E, and Medrol. My second transfer that failed, we also did doxycycline for 14 days, which I will be doing again. I just wanted to know if you've ever prescribed or suggested Viagra for your patients and what your thoughts on it. And if a 3rd transfer fails, what kind of tests or next steps do you do? Thank you again for all of your help, and I look forward to hearing the podcast.
I'm so sorry that you're having such a hard time when it comes to embryo transfer. I know this can be so frustrating. 1, you've got a good number of normal embryos. That should hopefully give you a little bit of peace. Number 2, I think about a lot of different things when it comes to transfer. Sounds like you've done controlled cycles every time, 1 time with Lupron. So I really put people into different categories. Did I like everything or did I not? Thoughts for me if this doesn't work or for the next time. If the lining is thin, do we need to change how we're getting an egg to grow? Meaning I often consider a modified natural cycle at this point where I'm getting you to grow an egg and therefore that egg is getting the lining to grow. This can be done naturally if you ovulate naturally, but more of us are doing cycles with either letrozole or FSH, so gonadotropins. These can be difficult because we don't know when exactly you're going to ovulate and you have to come in a lot and things aren't as planned. But I've seen people really respond differently. So if you have a thin lining, I would consider this. If you have a thin lining and you don't respond to that, so you have terrible PCOS and you don't want to use injectable hormones or there's some other reason why we don't want to do that, it is hard if you're older or if you don't respond or ovulate at all, to be fair. I sometimes use vaginal Viagra. I sometimes use vaginal estrogen or change up the road of the estrogen exposure if I think the lining should be thicker. If my lining's thin and at this point, only 5% of people are going to have recurrent implantation failure and failed 3 euploid embryo transfers. I'm doing a hysteroscopy. I want to put a camera inside your uterus and see if I'm missing anything. Do you potentially have endometriosis? Do you have painful periods? Do you have other autoimmune diseases? Does endo run in your family? Is your fertility unexplained? If this is the case, I gear back towards Lupron-based cycles and then consider longer pre-treatments with Lupron. Standard would be 2 months if we think it's endometriosis and implantation failure. These are also circumstances where we sometimes consider an ERA or an endometrial receptivity analysis test. This is a test where you do a biopsy sample to make sure that you're not missing somebody who might need longer or shorter duration of progesterone. This test was overdone. It probably has a small cohort of people who it's right for, and this may be the circumstance where we consider that. It does take you longer time and costs money, but it might give you an answer. And then personally, this is where I often would consider blood thinners for recurrent implantation failure, like baby aspirin and maybe Lovenox. There is some literature that this can be helpful for unexplained implantation failure. It's not excellent. I would want to make sure you don't have an underlying clotting disorder like factor V Leiden, any phospholipid antibody syndrome. Does anybody in your family have any blood clots? Have you? Is there anything in that realm? And the only reason I want to know that is it changes how long you need to be on the medication. Is it just for implantation or the first trimester? Or is this an entire pregnancy medication for you? So I'm thinking about, am I happy with the lining? Should I do surgery? Should I change the protocol? Do I have a thin lining? Do I have endometriosis? Do I have potentially a clotting disorder? And that's the basis of where I'm usually coming from in my brain when I'm walking through this implantation failure. Things I see most people not do is do a hysteroscopy to look at the uterus or to change anything in the protocol and just stick with the same protocol, even if we think somebody can have a better lining or there are signs that something could be wrong.
Hi, Natalie. I just had a question about starting my first round of Femara letrozole. I am 23. And I'm going to be starting in the next couple of weeks. As my doctor says, I think it's like day 4 through 7 of my period is when I start taking it. I was just wondering if there's anything that I can do to help it work better, per se, or like give myself the best chance with taking it. Do I take it at night or in the morning? My doctor said it didn't matter when. I do take my metformin at night. I have PCOS. I'm not sure if you can give me any tips or tricks or if there's anything I really can do to help improve my chances. Thank you.
Hi. Well, I know that having PCOS can be really tough, and I'm glad you're on the right medication. So letrozole is the thing that is standard of care for first-line ovulation induction. And you already did one of the things that I highly recommend, which is sounds like you're also on metformin as well. The combination of those together is really nice. Things that I think about. One, I like using letrozole earlier in the cycle. So if you get a choice on when to start it, would start it earlier. I would take it the same time every day. And I agree, morning or evening doesn't matter. So whatever is easier for you to be consistent with. I also like somebody to make sure that they're getting a good amount of sleep, not overdoing it on exercise. I wouldn't drink alcohol, smoke cigarettes, or use marijuana in this time period. Want to reduce the amount of processed and sugar foods. Supplement-wise, would consider prenatal vitamin, CoQ CoQ10, extra vitamin D, and inositol. That is my PCOS combination. Add in melatonin if somebody can't get enough good sleep at night, because sleep is really important in any inflammatory disease process, and we know that PCOS is definitely inflammatory. Ultimately, though, remember that there's different doses to letrozole. Depending on your doctor's plan, success is ovulating. So if you don't ovulate, that's not the end of the world, but then we want to change the dose. Regular OBGYNs, if you're seeing a regular OBGYN, are going to feel different about this. They may just try, and if you don't respond, kick you onto a fertility doctor. They may monitor with ultrasound, they may not. Everybody's different. You just want to know, how are we confirming that I did ovulate? Are we checking ultrasound? Are we checking ovulation kit? Are we checking progesterone? What is the game plan here? Therefore, you can know if you do. And then number 2, if I don't ovulate, what is going to be up next for me? Meaning, are we going to go up in dose? Are you going to get a referral? What is the plan? All right. Well, just a huge thank you to everybody who called and left a question. Again, these are my absolute favorite episodes. I just love hearing what you have and answering them. And I also think they're really fun and easy to listen to. A few housekeeping items just before you go. Remember, you can call and you can leave your own question. These questions can be anonymous if you want, but you do have a better chance of getting them answered. So go ahead and call 657-229-3672. Again, that is 657-229-3672. You can also ask your questions, if you don't want to leave a voicemail, on Instagram every Monday at Natalie Crawford MD. I'll answer some of your questions on Instagram, some of your questions here every week at the end of the podcast, and in the newsletter. You can sign up for the newsletter, nataliecrawfordmd.com/newsletter. And we also have the Enhance Your Natural Fertility course and the IVF add-on. These 2 courses are self-paced, go at your own. You're going to learn so much information. This is all information that exists in other places, but what you don't get is access to the community, to get questions, to monthly office hour calls. And I really feel like the program is curated so that you're learning things in a sequence that makes sense. I've loved watching people get pregnant and send back their praise for the course about how it empowered them and made them a better advocate for their own health, fertility, their care, all of the above. You can find more information out about the course offerings on the website as well, nataliecrawfordmd.com. All right, friends, thank you so much. And until next week, thanks for being here. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at Natalie Crawford MD and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.
Lee C. Camp here. If you've been enjoying this show, I think you might enjoy my podcast, No Small Endeavor, produced by Great Feeling Studios and PRX. No Small Endeavor explores what it means to live a good life. We sit down with courageous, impassioned people like actor Martin Sheen or civil rights hero James Lawson to ask what it means to live a life worth living. Follow No Small Endeavor wherever you get your podcasts. Living a good life is no small endeavor, and we would love to help.